Hello. Yeah. As I have finished with hernia, vascular system, and now I'm going to continue with the remaining part of trauma, which I had already started. And hello to you all. Probably you will be coming back to the college in the month of August, not before. It does not look like it. And so as you come, you will probably have your first internal. So you should be preparing, studying in the house. It is better if you do so. And today in trauma, I remember I had finished the basics of trauma. I had finished about head injury. I had finished about neck, and I had finished about thorax. The next most important and the place where maximum questions, either in theory or in entrance, are all clubbed in this particular part, that is abdomen. Abdomen is such a vast organ system that you need to know a lot of things about abdomen, and abdomen will not be an easy thing that you should just wing it, because whenever trauma is asked, they may ask you traumatic injuries of the liver, spleen, rarely pancreas and kidney. Then retroperitoneum I'll be covering in the next class. Today I'm exclusively, even if I'm going to complete the class in 35 minutes or 45 minutes or even 1 hour, I'm going to be only talking about only one particular system, that is abdomen. Whatever it takes, how much ever the questions are there or what, will be covered today in this particular class. So let's enter, and you guys should be listening, and at the end of the class I'll definitely take your questions. 1 minute. We will start about trauma to the abdomen. What is the most ominous sign whenever you see a patient with road traffic accident suspecting an abdominal trauma? 2 things. 1, an abrasion. If you see an abrasion on the abdomen, the chances are that the patient is suffering from an abdominal injury. And then, of course, a penetrating wound will automatically give you the sign. But even an abrasion, please remember this point, even an abrasion on the abdomen will give you a sign of internal damage. So, whenever there is a road traffic accident or a seat belt injury, okay, or a fist fight even, and then a penetrating trauma, that is gunshot wound or a stab with a knife, all these account for injury to the abdomen. So how do you know that a patient is suffering from a serious internal injury? And there are certain points here that you should remember, and they are all important. So these are one-liners that you should be remembering for life, not just here. So one is the abrasion. Okay, the first and the foremost thing is abrasion. Number 2, most common organ to be injured in blunt trauma abdomen, spleen greater than liver. This is in the GI tract. So most common organ to be injured when you have a seat belt pressure injury, it is mesentery. And most common organ to get injured in penetrating trauma is liver, followed by stomach, followed by small intestine, followed by small intestine. There are certain one point is that I will discuss here, which is the most common organ to be involved, or a sign that is involved in a blast injury is tympanic membrane. Tympanic membrane. Whenever there is a blast injury, please remember it is the organs that are hollow that are going to get affected. Number 1 is tympanic membrane, number 2 is lungs, number 3 is intestines. Please remember all these three. Okay, when I go to miscellaneous topics, there are certain important questions that are these days being asked in a lot of things, that is revised trauma score and MEGS. All these things I'll be telling in the miscellaneous topics, but right now come back to injury to the abdomen. Whenever there is an injury to the abdomen, okay, whenever there is an injury to the abdomen, blast injury, what is the most common organ that can get injured is ileocecal junction. Ileocecal junction. And also when there is a injury at the ligament of Tietz, that is the fixed point of the duodenum. Fixed point of the duodenum. So a patient comes to you with blunt trauma abdomen. How are you going to really work this patient up? Previously, DPL was the diagnostic tool of choice. Somehow, after the advent of CECT abdomen, we are not doing diagnostic peritoneal lavage. DPL is nothing but diagnostic peritoneal lavage, but diagnostic peritoneal lavage is a very, very, very important question, both in theory as well as your entrance point of view. Then you have FAST. FAST I already told you in the class previously, that is focused ultrasonar trauma. FAST is nothing but focused abdominal sonar trauma, ultrasound of the abdomen in a focused way in abdominal injury. And then CECT. What is the gold standard investigation of choice for a abdominal trauma, blunt trauma abdomen and penetrating? If the patient is stable, if it is not mentioned also, it is CECT abdomen. It is CECT abdomen. If the patient is unstable, then it is ultrasonography or FAST. Diagnostic peritoneal lavage is a historical point of view, but nevertheless I will be talking about it in detail. So whenever a patient is coming with RTA, with blunt trauma abdomen, what are the things that you're going to see? How will the patient present with? Most of the times the patient is in shock, because any internal organ bleed of the abdomen causes huge bleed. Liver trauma, splenic trauma, all these permanent blood supply is huge. So the amount of bleed they will bleed is so high. Okay, in the abdomen I'm not covering kidney also. For kidney I'll cover it in the retroperitoneum. That is in the retroperitoneum, that is the vascular structures as well as kidney. But today I'm going to only cover, or I'm only going to be focusing on abdomen. So anything that gets injured in the abdomen bleeds massively. Either even a penetrating trauma to the stomach, okay, or endoscopy in a penetrating injury. If you see blood in the stomach, it is an indication of injury to the stomach. Stomach is the second common organ to be injured in penetrating trauma. First is liver, second is stomach, third is the small intestine. In seatbelt injury, the first organ to be injured is the mesentery, followed by small intestine. Previously it was taught small intestine was the most common organ to be injured when you are having a penetrating trauma, but now it is no more. So the patient comes to you, the patient is in shock, the patient is confused, he is sick, he won't be able to tell you anything. So you have to understand what exactly could be the problem with the patient. So first thing you will see is if the patient has any abrasion on the abdomen. Abrasion on the abdomen is a clear indication that the patient has undergone, or the patient had got hurt internally, that is blunt trauma abdomen. If you see a penetrating wound, the most important thing that you will notice or you will check for is the involvement of the peritoneum. If there is a peritoneal breach or no. This is a very important question. Peritoneal breach is important in a case of abdominal penetrating trauma. Okay, why I am telling you, if the peritoneum is breached, we will go for a laparotomy. Otherwise, we will give a local good wash and then close the wound. So the whole treatment process is getting changed. So what are the organs that can get injured in a case of blunt trauma abdomen? As I told you, first spleen, followed by liver, followed by stomach, followed by small intestines. If it is penetrating, stomach comes into place. If it is a seatbelt retraction injury, it is your mesenteric. Whenever the mesenteric injury is there, you have to see if it is a horizontal tear or a vertical tear, transverse tear or a vertical tear. If it's a transverse tear, the prognosis is good. If it is a vertical tear, the prognosis is bad. Please remember this point. Please remember this point. Vertical, okay? The chances of more blood vessels getting injured, so the losing of the patient prognosis is poor. When it is a horizontal tear in the mesentery, the chances of patient survival or prognosis is quite good. Okay, but at the end of the day, how much and when you're going to open the abdomen also is important in this particular point. So once you see this, then you should understand. You've seen a patient with operation, you have examined, the abdomen is tender, distended. Distension clearly means it is hemoperitoneum. Please remember, hemoperitoneum will always cause distension. Why? Because blood is such an irritant to your peritoneum. Okay, such injury to the peritoneum. So you have to be very careful. So abdomen is distended, tender. Patient is in shock. Confused. There is tachycardia. Then there is low blood pressure. Tachycardia, low blood pressure, hypoxia. All these signs will take you to one particular thing, that abdomen is not right. First I go, what are the things that you're going to do? What are the investigations that you're going to do? And followed by what are the treatment modalities that are available, and what are each organs, if they're injured, what exactly are we going to see? Okay, so the number one, the first and the foremost in abdominal trauma that you want to do is, previously was done, is a diagnostic peritoneal lavage. How do you do this diagnostic peritoneal lavage? You will give a vertical midline incision above the umbilicus or below the umbilicus. You will breach the peritoneum and then draw a 10 cc, okay, 10 cc blood or whatever free fluid from the abdomen. Subject that to a laboratory testing. If there are about 1 lakh RBCs, please remember 1 lakh RBCs, 500 WBCs, and in that 10 ml, if you have bile, okay, it is a confirmatory test that either the liver or the duodenum is injured. So that is, then you will have to think whether to open the abdomen or no. Okay, how much amount of free fluid is there in the abdomen? That is checked by an ultrasound. Once you see this ultrasound, if the blood in the peritoneal cavity is in the tune of 1000 ml or actually 1500 ml, there is no option but to do an emergency laparotomy. And a laparotomy incision is nothing but a midline incision. You breach through the rectus sheath vertically, and then you will see how it is going to happen. Is that clear? Yeah. Then once you see this, once you open, then this is DPL. First thing about DPL. Then we will move around focused abdominal sonar trauma, that is FAST. You will see a focused checking areas where you expect damage to organs. So there are 4 parts that you need to be checking, and these 4 parts include just below the xiphisternum, right hypochondrium, left hypochondrium, and then suprapubic region. If you add two more structures, that is left loin and the right loin, that becomes a fully focused sonar trauma abdomen. But it is 4 points that you should check. Number 1 is just below the sternum, right hypochondrium, left hypochondrium, and the suprapubic region, that is pelvis basically. So focused ultrasound sonar trauma will give you the amount of blood that is free fluid that is floating in the abdomen, number 1. It will also give you the amount of the solid organ that got injured, either the spleen, either the liver, or mesenteric tear, maybe, but we don't know if we can really check about it. But blood, the amount of blood, the free fluid will give us an idea whether we have to open the abdomen. And when you do a focused sonar trauma using an ultrasound probe, you can take a sample of the free fluid. That is USG guided. So it will also help you to check if there is blood. Then you have the gold standard investigation. If the patient is stable, please remember, it is the investigation of choice or the investigation of choice if the patient is stable. If the patient is unstable, it is your ultrasound or FAST, F-A-S-T, FAST. Diagnostic peritoneal lavage was previously done but not done anymore. So we may not have to be talking about DPL a lot, but these are the things that you should remember. What exactly do you do in diagnostic peritoneal lavage? Where is the incision? How do you breach? How do you check? Then how much ml of blood is collected? How and what are the tests this blood will undergo? What are the things that you check in this particular blood also need to be seen in diagnostic peritoneal lavage. Okay, once you have seen, there are 2 solid organs that can get injured, that is spleen and liver. Most common. So if spleen is injured, you have to see what is the amount of injury. Number 1, stage 1 is about 10% subcapsular hematoma or a laceration of about 1 centimeter. If it is 10 to 50, and your laceration is about 1 to 3 centimeters, is stage 2. With 75% avulsion, 75% of subcapsular hematoma and greater than 3 centimeters of laceration, splenic laceration, it is 3. 4th is if stage 4 or stage 4 grade 4 injury, then 25% devascularization of the spleen and 5, that is 5th stage or grade 5 of splenic trauma is nothing but avulsion of the splenic hilum. So these are the 5 grades of splenic injury. 1, 2, probably 3. 1, 2, 3. We can probably wait and watch if it is progressively bleeding any further or no. In case of splenic injury, you will know. You will do a CT if the patient is stable. You will know what exactly is the injury, what is the amount of laceration, what is the amount of devascularization of the spleen that has taken place. So once you know, 1, 2, definitely medical management. 3, doubtful, but most of them you can observe by doing a continuous ultrasound or CT scan regularly. And if it is 4 and 5, there is no question but you do a splenectomy. You do a splenectomy. Okay, there is something called as Kerr sign, K-H-E-R, Kerr sign, which means whenever there is an injury to the spleen and it is bleeding, there is always pain in the left supraclavicular fossa because of the nervous radiation. Okay, that is called radiation pain. You know already about it. So this you have to remember. Grading of splenic trauma, what exactly you are doing, and there is a controversy when splenic injury is there. Do you give pneumococcal vaccine, H influenza vaccine before the surgery? It is not recommended. You have to give the patient within 14 to 1 month after the surgery. After the surgery for pneumococcal and H influenza vaccine. H influenza vaccine. Is that clear? That is about splenic trauma. Then the next most common is the liver. In the liver trauma, again it is to be graded as I told you previously. How it is graded? It is graded just like your liver. If there is a capsular hematoma of 10 to 25% or 1 centimeter laceration, okay, 1 centimeter laceration, it is grade 1. When it is 25 to 50% or 1 to 3 centimeter laceration, it is grade 2. If the laceration is up to 75% subcapsular hematoma and greater than 3 centimeter, it is 3. And the grade 4, when one lobe is 75% damaged, and grade 5 is avulsion of the portal triad. Portal triad. Here 4 and 5 will need definitive surgeries, and because liver usually, yes, so when this injury is there, liver trauma, you have to open. You please remember, whenever you open, the bleeding of liver bed does not stop easily. Then there is something called as you advocate something called as Pringle's maneuver. Intermittently, you will be pressing on the portal triad. You will be pressing on the portal triad intermittently, and then you will be packing the liver bed that gets injured. So you will pack with hemostats, you will try to cauterize, or you will put a mop, or you will keep a sponge foam to control the bleeding. And most of the times when there are multiple injuries in the abdomen, there is something called as, please remember, something called as damage control surgery. This damage control surgery is in 3 parts. Initially, you will do only that part to make the patient survive. The patient should survive that first surgery. If you don't do, the patient is going to die. So you do minimal surgery to save the patient. Then you will resuscitate the patient in the ICU, and then you will do a redo laparotomy. Okay, especially in liver trauma. And you will do a laparotomy and you don't close the wound totally. You will do a laparostomy by putting a Bagota bag. Okay, because you pack the liver with a lot of foreign material that has to be removed. You will put a mesh or you will put a Bagota bag and then get the abdomen closed and leave it like that. And leave it like that. Pringle's maneuver, packing are the 2 causes, and then you will see if the devitalized this liver will be removed or what. You will plan it at a later date. So you don't want the patient to die. Right now you will do what you called as damage control surgery. Damage control surgery. Damage control surgery is the mainstay of treatment in these days of liver injuries especially. Whenever there is a right hepatic artery injury and you want to ligate the right hepatic artery, you will use a zero chromic catgut. Please remember, this is an entrance fault. Zero chromic catgut. And whenever you're doing a right hepatic artery ligation, you will have to do a cholecystectomy. This is also an entrance fault. You'll have to do a cholecystectomy. This is also an entrance fault. So in liver trauma, you have to do a packing, you have to do a laparostomy. And remember, you can never ligate the bile duct. You can only ligate right hepatic artery. Other arteries have to be repaired. If you are trying to ligate the right hepatic artery, it is zero chromic catgut that you're going to use, and you will have to perform a cholecystectomy. You have to perform a cholecystectomy. So you will do a damage control surgery, resuscitate the patient for next 72 hours in the SICU. Maybe if you want to ventilate, you ventilate. If you don't want to ventilate, you don't want to ventilate. But most of the times, with so many injuries, the patient will probably need your ventilation. And in SONAR FAST fast, if you're also checking the lung fields, that is right and left, that becomes a total fast. Okay, so then you do this and you will have to put the patient on a ventilator, or however you want to manage. You have to resuscitate, adequate amount of blood to be replaced, the amount of fluid the patient wants need to be given, and then you have to give it to, and then you have to plan the next surgery. Either an injured bowel is there, because the chances are very high. So what you will do next after the damage control surgery, please remember, any abdominal injuries, you have to put 2 abdominal drains, one in the Morrison's pouch and one in the pelvis, so that no collection stays there and everything comes out, so that we assess the patient properly. Bagot band, laparostomy, midline incision, all these things are important. So what is the incision that you give? Is midline laparotomy incision. Anywhere, no question of you giving any other incision. Liver trauma, splenic trauma, all traumas, you have to give a midline incision. If there are small bowel injuries, the tears in the bowel, you will have to do a primary closure for small intestine. Primary closure of the small intestines. Unless and until the mesentery tear is there and devitalized, you don't do a resection anastomosis. And whenever you have cecal tear or terminal ileum near to the cecum or ascending colon injury, you have to do a iliotransverse anastomosis. Please remember this point. Iliotransverse anastomosis with again 2 tube drains. You will do a primary closure. And you will put 2 tube drains. Then you have pancreatic injury. I'll further cover it in retroperitoneum. Again, it is 10%, but pancreatic injuries are quite dangerous because you may end up, the injury itself can end up doing a part 2 duodenal injury. If the duodenal part 2 gets injured, then you have to do, please remember these 3 points. You have to do a gastrostomy, you have to do a duodenostomy, and then you have to do a feeding jejunostomy. Gastrostomy, duodenostomy, and you do a feeding jejunostomy. These are the 3 points that you have to remember whenever you're doing surgery in an injured second part of the duodenum. First part of the duodenum, third part of the duodenum, you can simply suture, probably put a omental patch. But in the second grade, you have to remember that you have to do a gastrostomy, you have to do a duodenostomy, and then you have to do a feeding jejunostomy. If the pancreas is injured, most of the times you may have to end up doing a lateral distal pancreatectomy. You have to do a distal pancreatectomy or a Whipple's procedure also. Or a Whipple's procedure also. Whipple's procedure in detail I'll talk when we are talking about retroperitoneal hematoma or retroperitoneal structure injury, that is kidney, peritoneum, a little about colon then, and yeah. And whenever there is a trauma in the lions, you have to remember there are 4 vital structures that can get injured: colon, kidney in the lions, ureter, and renal artery. These are the 4 important structures that can get injured when there is a trauma to the loins of both sides. Loins of both sides. So once you see this, you do a laparostomy and damage control surgery, resuscitation, and a full-fledged surgery. Injury to the bowel, you will close primary for small intestine unless until there is devitalized blood supply, as in mesentery tear. You will do a resection and anastomosis. If you see a cecal injury, you probably have to do iliotransverse primary closure, iliotransverse and anastomosis. Iliotransverse and anastomosis. Stomach, you do a primary closure of the stomach, and you will apply a omental patch. First of all, you have to debride all the devitalized stomach or the intestinal part, and then suture. Main vessels I'll be talking later. Once you see this, okay, this thing is settled. Once the patient becomes alright, you may have to go for other part surgeries like bone fractures, etc. etc. This is done, okay. Then we'll come to something called as abdominal compartment syndrome. Abdominal compartment syndrome is important. Please remember, whenever the pressure in the abdomen, rises to 25 millimeters of mercury, it is called as abdominal compartment syndrome. So what is the normal pressure in the abdominal cavity? 3 to 5 millimeters of mercury. 7 to 12 millimeters of mercury pressure rise in the abdomen is called as intra-abdominal hypertension. Intra-abdominal hypertension, IAH, intra-abdominal hypertension. Anything above 25 is considered as abdominal compartment syndrome. So where do you see abdominal compartment syndrome? Trauma, injury to the major organs, post-laparotomy, burns, and you have to remember another thing, that is secondary cause, that is your malrotation of the gut. These are the things that will cause raised intra-abdominal pressure greater than 25 millimeters of mercury, and this is called as abdominal compartment syndrome. So 3 to 5 is the normal pressure, 7 to 12 is intra-abdominal hypertension, and greater than 25 millimeters of mercury is called as abdominal compartment syndrome. So there are 3-4 stages of abdominal compartment syndrome. Number 1 is when the pressure is 25 millimeters of mercury with patient absolutely stable. Okay, what you do, you continuously monitor the patient and you will do normal volumic resuscitation. 25 to 30, the patient will be oliguric. You may have to do a laparotomy. 30 to 35 millimeters of mercury. Okay, 30 to 35 millimeters of mercury. It indicates the patient is in anuria. Multiple organs are getting damaged. So what are the organs that are getting affected when you have abdominal compartment syndrome? Number 1 is because the abdomen pressure is rising beyond its capacity, the lungs are going to get affected, the diaphragms are going to get paralyzed, okay, the vital abdominal structures are getting compressed, they become edematous, and ultimately this. And you please remember, shock increases or forces abdominal compartment syndrome. Always shock should be there if you call somebody abdominal compartment syndrome. Why I tell you? Because when the patient is in shock, the intestines are going to become edematous because of lack of blood supply. And this edematous intestines are only going to get swollen and thereby worsening your abdominal compartment syndrome. So you have to remember, shock is the reason for abdominal compartment syndrome. Abdominal compartment syndrome. So you have diagnosed, then how do you measure what is the pressure in the abdominal compartment? You have to put a 3-way Foley's catheter and then measure the intra-abdominal pressure. 3-way Foley's catheter. This is gold standard investigation of choice. Gold standard investigation of choice and an entrance bit in abdominal compartment syndrome. So what exactly? You will put a 3-way and thereby measuring the intra-abdominal pressure. Intra-abdominal pressure. How do you relieve once you have diagnosed? You cannot wait because all the vital structures are getting damaged. So you will do a laparotomy, midline laparotomy incision. You will do a midline laparotomy incision. If need be, you will only do a damage control surgery. But please remember, the stage 4, grade 4 of abdominal injury is because of already doing a laparotomy, and the pressure of intra-abdominal pressure is greater than 35 millimeters of mercury. 35 millimeters of mercury, that is when you will do a re-exploration. So what is the investigation of choice for intra-abdominal pressure rising? Is your 3-way Foley's catheterization. 3 ways Foley's catheterization. So you need to put the patient most probably on mechanical ventilation because of the abdominal compartment syndrome. The lungs have got collapse. Lungs collapse. That's called as atelectasis. Once all this happens, you will do a laparotomy. Okay. Again here you will put up a go-to bag or a mesh, close it, and then come back. Once the pressure starts becoming normal, once the pressure starts getting normalized, that is when you will do a closure. You will do a abdominal wall closure. Prognosis: about 30% of the people with abdominal compartment syndrome die. So the prognosis is generally bad. Anything above 30, anything above 15 itself is bad prognosis. But here it is more than 35%. So you need to be more cautious in dealing with the case of abdominal compartment syndrome. Abdominal compartment syndrome. So once the abdominal compartment syndrome is there, you have to be extra careful. You have to investigate the patient thoroughly, put a Foley's catheterization, monitor urinary output, and also you have to see that the patient does not collapse. And you will do a laparotomy as the sign of anuria is there in intra-abdominal compartment syndrome. Intra-abdominal compartment syndrome. And as this continuously progresses, you have to do a laparostomy. You have to put a Bagota bag, you have to put a mesh and not close the abdomen fully. The abdomen, only the skin you close and leave the abdomen so that it gets space for expanding. Patient should be, most probably he'll end up on a ventilator, on mechanical ventilatory support. To give lower of oxygen. All these points to be noted. Okay, all these points are to be noted, and because there are multiple questions that are coming from abdominal wall injury. Then as I told you, whenever there is a penetrating trauma to the abdomen, the first and the foremost site that you check is if there is a breach in the peritoneum. If a peritoneal breach is there, you have to invariably do a laparotomy. You open the abdomen midline incision, you check if there is any organ or vital structures of intestines that get which get injured. You have to primary closure. If there is no soiling, primary closure. Wash thoroughly and put a drain and come out after a thorough wash. If there is soiling, then you do a iliotransverse anastomosis and put a ileostomy or transverse colostomy. I told you already about Trimbles manure. I told you about the grades of liver injury, grades of splenic injury, and when splenic injury, splenectomy, and when it is liver injury, more about packing and controlling the bleed. And as these conditions improve over a period of time, as the patient gets better, you will see that the patient is improving. Then you have the most common seat belt pressure injury. Okay, seat belt pressure injury, there are two places that are going to get severely affected. One is the ileocecal junction and the ligament of teats, where the T2 is fixed. And the chances of a seat belt injury, the mesenteric tear. Okay, I don't know what I told you previously. Or is transverse and what is it? What is a transverse incision? Transverse or a vertical incision. Vertical incision is this. Transverse incision is a horizontal incision. So whenever the mesenteric tear is a horizontal one, that is transverse one, the chances of the particular organ or the intestine part in getting injured is quite high. So a transverse mesenteric tear is life-threatening, unlike a longitudinal vertical mesenteric tear. Vertical mesenteric tear carries good prognosis, and a horizontal mesenteric tear will carry bad prognosis. So once you see this, you have to keep in mind how viable is the intestine when you are dealing with mesenteric injury. If the intestine has become devitalized, you will do a end-to-end anastomosis in a small bowel. If it is large, you will do a end-to-side anastomosis with the small bowel and the large bowel, doing a resection of the whole devitalized intestines. Clear? So transverse tear carries poor prognosis, vertical tear carries good prognosis in a case of abdominal mesenteric tear. So this is all about your abdominal penetrating trauma of the abdomen as well as blunt trauma of the abdomen. So many points that are important for your theory as well as entrance I have covered. Hopefully that you follow all this, make a notes of it, because many of these are not covered in your entrance classes, I'm damn sure. And these are the questions that usually come, because I've seen certain online preparation subjects, they're not so perfect. I'm not telling I am perfect, I'm only telling that you need to learn extra. So only videos is not the point. You have to read other books to understand what exactly is there. So it is imperative for you to learn everything in detail. I have tried to give the best possible I can do. Some you can follow. If you don't follow, you always have your books to read. And as you progress, then next I'll talk about retroperitoneum and vascular structures. Then I'll see what are the miscellaneous topics that we should be covering in the vascular system. So this will be our 5th class in trauma or 4th class in trauma. Next will be 5. 6 classes allotted, so I'll be finishing trauma in the next class, and I want you all to come prepared. And anybody has any questions to ask? I'm just opening. If you have questions, please ask. I'm here. So many of you give attendance and go, right? Because only 14 people right now are active. All the others have gone, right? Anyways, I'm not bothered. You're going to suffer, you suffer. Right now, anybody has any questions? Ready to take? In abdomen, trauma abdomen. No one has any question. So all of you are perfect. To be believed. Any more questions, please? Srinivas is wishing me thank you, which means he's present. Of the 11 people, he's there. Oh, Manish also is here. Fine. How are you guys? Okay, see you with retroperitoneal trauma and vascular trauma in the coming class. And then I'll talk about, as I told you, revised trauma scope, TRIS as well as MEGS. These are not for your theory, but they're more for entrance point of view. I shall cover those in the next class. That should probably finish our trauma. Will not have anything much. Okay, bye.